Good morning, everyone. I'm Zach Kacharski. I'm the executive editor at the Gazette in Cedar Rapids. And this is session two, and we are going to talk about cancer in Iowa. And kind of the preamble is that Iowa's cancer rate is second only to Kentucky, with more than 20,000 new instances of cancer expected to be diagnosed in Iowa this year. Why is the rate so high, and what can be done to bring down the trend? This is going to be a conversation that I expect will go far beyond that. And just in the few minutes gathered ahead, there's a lot of positivity in the group here. And so I'm going to introduce the panelists, and we will kind of have a jumping off question. But as I introduce you, I was hoping that each of you could maybe speak a little bit about your experience, and then I'll open with an opening question. And Dr. Deming, I'll start with you. Dr. Deming is from Mercy One's Richard Deming Cancer Center as the medical director, as well as the founder of Above and Beyond Cancer.
Well, thank you. It's an honor to be here. Yeah, so I turned 70 this year. I've been a doc for 43 years. Gives me a tremendous perspective on where we've been and where we're going. And I would say I'm most excited about the fact that there's never been a time where developments have been coming so fast and furious and quickly. So I'm excited to talk about, where we've been, but more importantly, where we're going. But I'm also very interested in the intersection of medicine and humanities. So I'm not a researcher that works in a lab. I do clinical research, but most of my life is one patient at a time with a patient and a family, talking to them. And no matter how fancy and sophisticated our treatments get, ultimately, a doctor taking care of a patient is a human being caring for another human being. So I'm very interested in how we maintain what we would call medical humanities, or keeping the human aspect of taking care of patients and their families. So those are a couple of things I'm excited to talk about today.
All right, well, thank you. Rachel Schramm is the program manager for the Iowa Cancer Consortium. Rachel, welcome.
Hi, Zach. Thanks for having us here. Like Zach said, my name's Rachel. I am like a public health person through and through. So I have a lot of experience working at the state and local level, at different health departments, mainly working in cancer. That's never what I thought that I would do with my public health degree, but I actually love it. So my organization, we work across the state to really develop partnerships, so that we don't have to recreate the wheel when it comes to cancer prevention, screening, treatment, and quality of life, that we can really put great minds together and figure out new ways to make cancer less of a burden.
All right. Dr. Michael Henry is the interim director of the University of Iowa Holden Comprehensive Cancer Center and the professor of in the UI Department of Molecular Physiology and Biophysics. Award for the longest title, I think, this morning. But Dr. Henry.
Hi, thanks, Zach, and thank you all for coming. So I unlike Dr. Deming, I actually have been in the lab for about 30 years doing cancer research. And prior to coming to Iowa, I actually worked at a company, a pharmaceutical company. So I've seen the process of discovering and developing drugs from that perspective as well. My lab works on how cancer spreads from one place to another in the body, and we're interested at a very basic level, but with the prospect of translating it into new ways to diagnose or treat cancer. And I'm delighted to have stepped in to the directorship, an interim directorship of the Holden Comprehensive Cancer Center after George Weiner's 25 years of leadership. So some big shoes to fill, and very happy to be in this spot and to talk to you today.
Right, thank you. Sarah Nash is assistant professor of epidemiology at the University of Iowa, and she oversees the research and data use for the Iowa Cancer Registry.
Thanks, Zach. Thanks, everyone, for being here. It's a really wonderful panel. I'm just really excited to be speaking with everyone. So as Zach said, I'm an assistant professor of epidemiology at the University of Iowa. A couple of roles I have in that. I oversee kind of data use and research at the Iowa Cancer Registry. I've most of my experience is actually in the registry system. So I'm fairly new to Iowa. I've only been in Iowa a couple of years. I moved from Alaska a couple of years ago, where I oversaw a cancer registry there. And, Dr. Deming, I was really thinking about what you were saying about the humanity of medical care. And I feel the same way about the registry. And I feel, Zach, you gave that statistic about 20,000 new cases of cancer in Iowa this year. And every number that we have in the registry is a story, right? It's a story of somebody's diagnosis, it's a story of somebody's treatment, and it's a story, most importantly, of somebody's survivorship. And so I really kind of, that's the approach that I like to take when I'm thinking about cancer data. I think about cancer data a lot. And then I also get the privilege of working with the Holden Comprehensive Cancer Center to do some community outreach and engagement work. So I'm really grateful to be involved in both of those things, because I think I've learned so much about cancer in Iowa in the last couple of years since I've moved down south from Alaska.
Drawn by the weather, I'm sure.
I actually love the Alaska. I was in Anchorage. The weather was pretty mild. I enjoyed it a lot.
But
All
Sarah,
right.
that does not sound like an Alaskan accent to me.
It is not. I'm originally from England, and I kind of moved to Alaska to do grad school and loved it and never left until I moved to Iowa.
All right. Well, I think, as I said at the onset, that Iowa was the only state with an increasing cancer rate. Yet there have been significant improvements in care, as Dr. Deming has mentioned, and it's something that impacts everyone in a variety of ways. Whether you have it, a family member has it, there's policy issues associated with that. But I'm curious, kind of as a level set question, what has you optimistic about where things are right now, but what also has you concerned? Dr. Deming, I'll keep the same order last time and start with you and go around the square.
Yeah, well, thank you. So I'm optimistic about the number of new treatments that we're seeing come down and become activated. And we can get into the details. I mean, in the last several years, immunotherapy has just revolutionized the way we treat some types of cancer. In particular, let's just talk melanoma. I mean, President Carter has just had his 99th birthday, stage 4 melanoma with liver metastases, brain metastases. I only know what read in the public, and that would have resulted in death within just a year or so. We now can control what would have been an incurable cancer, and we're seeing more progress in other types of cancers. So that is coming fast and furious. So I'm excited about that. What gives me pause? Cancer affects everyone, but it doesn't affect everyone equally. And we know that vulnerable populations, even in the richest country in the world, have difficulty with the same degree of access to early detection, screening, treatments, and care. And that gives me pause and makes me concerned. So we can talk about some of the systemic issues and kind of the healthcare delivery. But when we look at the basic science, we're making tremendous progress, and that's what makes me excited.
Rachel.
I think I'm really optimistic just about how technology can connect us across the state. We know that there's rural disparities. Folks don't have access to maybe a provider or the treatment that they may need. So I'm really excited just to see how like AI, biomarker testing and, even Zoom for our coalition has really helped us stay connected. So I'm excited about that. Concerns, definitely just the decreased investments in public health, especially since the COVID-19 pandemic, just seeing how that impacts us. And, like Dr. Deming said, it doesn't affect everyone equally. So things like Medicaid unwinding, decreased funding for different state cancer screening and public health programs, closures of rural hospitals, and, just kind of those provider deserts that we see in the state. Those are things that concern me a lot.
All right, Dr. Henry.
Thanks. Yeah. So I would agree with Dr. Deming about the excitement about some of the therapeutic modalities. Just some other things that are going on that we're doing in Iowa. There's a type of therapy called theranostics where you combine the ability to see the cancer in the body with an ability to treat it. And the first few drugs in this space have been approved by the FDA, and it's a new way to treat certain types of cancer, and has had some impact in advanced prostate cancer, for instance. Another thing that's not yet ready for prime time, but is, I think, very interesting on the horizon, are blood-based multi-cancer detection tests. These would be tests that from a blood sample, you might be able to know very early whether you have certain types of cancer. Still in the research phase, but it's something that I think you can see just over the horizon that will change the way we screen for many different types of cancers. Another thing is AI. You know, how is AI going to affect how care is delivered and optimized, how patients are identified for what sort of care pattern or clinical trial might be best in their case. I think we're at early days of knowing what this might bring to patients as well. In terms of concerns, I agree with Richard and Rachel. Access, you know, if we could bring the things that we can do now, not to mention all of those things I just mentioned, if we could do better at delivering what we know how to do now, we could have a huge impact on cancer. And so I completely agree that access is one of the main things that is still an issue. Yeah.
Okay, thank you. Sarah.
How do you top all of that? I think everyone has made really great points. Just a couple of things that I'd either like to pick up on or just add to. Dr. Deming made a comment about equity. I mean, I think about equity a lot, not only in access to healthcare, but also in access to healthy behaviors and social drivers of health, things that are really, you know, when we think about the development of cancer, the behaviors that we're engaging in today are going to be the cancers that we're seeing in the registry in 10 to 15 years' time. So how can we help everybody access healthy lifestyles, physical activity, fruits and vegetables, cancer screenings, all of these different things? And I know we'll kind of dig into that a little bit more, but it also goes deeper into those social drivers of health, right? We can think about financial security, we can think about education, all of these things that are really upstream. So I think about that a lot. I'd be remiss if I didn't kind of pull us back to from being from the Iowa Cancer Registry to that statistic of us being second in the nation. I think that's something that we're thinking a lot about at the registry. And I think this also segues me in nicely to the thing that I'm really excited about in Iowa, and that is the partnership. When we put out the Cancer in Iowa report that really presented that statistic, everybody has really rallied around that and said, what can we do? How can we help? And, I have to give a huge shout out to the Iowa Cancer Consortium, who's been just really wonderful for longer than I have been in the state of Iowa at really bringing partners together to really address how we can begin to lower those rates, to lower the burden of cancer, and really kind of bring partners together to do that. So that's what I'm excited about. I've never been anywhere more collaborative than Iowa.
Right. Well, before we leave that topic, Rachel, can you talk a little bit about the effort that is underway for that collaboration? What does it look like? And what has the response been
to the report? Yeah, it's been really interesting to just be on the side of really trying to amplify the work of the Cancer Registry. And, we kind of serve as that go in between, that we're also fielding questions from communities about different things. Like, we think that we have a cancer cluster of, teachers in a school, or just kind of fielding some of those questions and being able to link them to the experts that are there. Our job at the consortium isn't necessarily to do the research and figure out what's going on. We leave that to the different academic institutions, but our job is to really bring people together, just like this, to have a conversation about what do we know as a collective, and what do we still need to figure out, and rallying people around that.
Right. I was also curious. Several of you brought up access, and that can have a lot of different. There's geographic access. There's also insurance or healthcare. And I was curious, maybe starting with geographic, what impact does where you are in the state have to the level of care that you have? And we can expand on access, maybe non-geographic after.
So this is Dick, and I have the opportunity to also do an outreach clinic in a more rural area besides Des Moines. And geography does make a difference. I think it's not the most important access issue. I think the financial access is probably bigger, but definitely access. So if you live in a rural setting, you may have a hospital. It may or may not have cancer services available. Most hospitals in rural Des Moines have some sort of affiliation with one of the health systems, whether it is Unity Point or Mercy or the University of Iowa or others. So you do have the ability to access the type of service that can be done at a tertiary care facility, but getting there, and not only the car or the transportation to get you there, but do you have childcare to take care of folks back home? Do you have the ability to get off of work? So those all factor in. Even in the most rural setting of Iowa, if you have the financial ability to, for the most part, have a cell phone, have access to the internet, and have the ability to get the care you need. You may have to drive for it. It may be more inconvenient, but you do have the ability to get it. And I think that statistics show that throughout the country, Iowa time and again delivers the highest quality of healthcare. So although geography plays a role, it's not as big of a barrier to access to care as financial and other social concerns.
Right. Well, without hearing others jumping in on that, I will assume there's agreement.
Oh, Michael's muted.
Dr. Henry muted himself. Vicki, can you help unmute Dr. Henry?
There we go. Yeah, I didn't want my cough to interrupt Dr. Deming's response there. So yeah, no, I would just say, we know that patients want to get the best care closest to where they live. And, in a state like ours, with rural areas, it can be challenging, particularly when it comes to accessing clinical trials. Some of these really involve, intense regimens that would, have you, coming to the hospital very frequently to get that care. And so one of the things that we're thinking about at the Holden Comprehensive Cancer Center is how we can, do better at making clinical trials accessible to folks away from the center. There's still a lot of work to do there, and there are other entities in the state that are also involved in this effort. But people really would like to get the best care that they can get, the closest they can to home, for sure.
How much of that gets worked into the model of care? Because obviously when you get a diagnosis, there are a lot of factors that will change, and work may change, all sorts of things that have been supporting the lifestyle. How much do you work that into, Dr. Deming, I think this is one maybe to come right at you, to that delivery of care from the onset?
Well, definitely. And I would say that as systems develop, we are able to be more efficient at doing that. So, for example, Mercy One Cancer Center, our group of medical oncologists have 22 outreach clinics. So they have 3 within Des Moines and 22 outreach clinics where instead of having the patients drive to Des Moines, they send a provider as far away as Atlantic and Fort Dodge and Centerville, Iowa, and I'm not going to name all 22, but by having systems so where you systematically figure out, okay, how can you deliver the most care you can in an outlying center? There's always going to be certain highly technical or very complex treatments that will require the patient to come to a tertiary care center, such as, Des Moines University of Iowa or any other regional hubs. But the ability to deliver the care, mostly the care when you come to delivering radiation or you deliver chemotherapy, the actual cancer treatment requires the provider to be on site. When it's a consultative service or a follow-up service, we're utilizing Zoom just like we are now. So when you can safely deliver the care to a remote area where you might have a local doctor or nurse practitioner on site, but take advantage of the specialist care via Zoom, that's also a way that systematically we've been able to expand the amount of care that is being done out in the rural center.
All right. Dr. Henry, I know with Holden Comprehensive Cancer Center as well. Do you have thoughts on this?
Yeah, there's different models of doing this as well. And I mean, one of the lessons from COVID is that we could be doing more with telehealth. So we're piloting a collaborative consult program where some of our medical oncologists, where, one of the things about a center like ours, we have specialists that see a lot of the same type of cancer and really, have seen the different faces that it presents to patients. And, that can help folks at other centers that in more rural settings that don't see as many of the same types of cancer. They don't have as much experience with it. So the ability to network with some of the folks here to discuss the case and to get some perspective can be helpful to bring the best outcome to the patient.
And just to amplify that, I mean, just now, actually, I was texting the sarcoma expert at the University of Iowa, collaborating on a patient that might still get all the treatment here, but taking advantage of this highly specialized expert at the University of Iowa. Also might throw out that, at Mercy One Cancer Center, we have 12 multidisciplinary cancer conferences a month where we talk about different cases. And on one of them, our head and neck cancer conference, the head and neck cancer surgeons at the University of Iowa are participating in the Mercy One cancer conferences. So it works not only to connect experts with patients, but experts with care providers and physicians. So that's a change that wouldn't have happened 20 years ago, and the ability for patients to connect with caregivers and for docs around the state to connect with each other has really expanded due to this collaborative approach that we have here in Iowa.
Yeah, it's really important, and particularly in some disciplines like head and neck surgery, there are just not a lot of people around that can do those complex cases, and being able to work with folks all over the state is really important.
Okay, we have a question from the audience, and I want to work it in here as a reminder that folks that are watching can ask questions using the chat button at the bottom and submit them, and I'll work them in. And the question is around some of the data and the factors related to the rate. Are you looking at access to care, the lack of screenings, different exposures, other behaviors? When you're looking at why is Iowa's rate different than other states?
I mean, I can start this and then I'll hand it off to my fellow panelists. But I think I had a great saying the other day that I think really describes this. And it's really a mountain of pebbles. I don't think when we look at Iowa's risk factor profiles, there's nothing that really jumps out to us at the registry as this is most certainly it. But, you know, we still have 15% of our population that use tobacco. Only 7% of our folks in Iowa are consuming the recommended amounts of fruits and vegetables. We could be engaging in more physical activity. We have higher of the national obesity prevalence. We drink more alcohol than we do nationwide. There is a potential role of environmental exposures. So I think it's not necessarily one of these things in particular, but we're kind of thinking about the idea that it's probably a combination of all of these things, in addition to things like access to screening, access to care. All of these things kind of together are really shaping that rate.
This is Dick. So Sarah is an epidemiologist. She's a scientist, and I really appreciate how she kind of stays in the lanes. So I'm going to speculate, so that I don't have data on this. But when you look at what's different about Iowa, when you just look at all of the other states, bring up a map. So there are two things that I'm going to suggest need more study before we can say, but two things where I think Iowa clearly is different than any other state in the union is, number one, radon. We are sitting on a huge bed of radon, probably more than any other state. We know that it increases the risk of lung cancer. I suspect that with more study, we will find that it also increases the risk of other types of cancers, and maybe we don't know the mechanism yet, but that we will figure that out. So I suggest that the radon may be one of the reasons. And then second, I mean, if you did an aerial map of Iowa, we are river to river and north to south, a bath of ag chemicals, herbicides, pesticides, fertilizers, nitrates. We are not at the point where we can link like cigarette smoking to lung cancer. We're not yet at the point that we can say what every single chemical that ultimately gets into our water supply, into our skin, into causes. But when you look at the amount of ag chemicals Iowans are exposed to compared to other states, I suspect that we'll find that might also be one of the contributing factors.
And if I could just bounce off that to bring back to the thing that I was optimistic about, which was partnership. And, you know, that's something, Dr. Deming, that we've been really interested in. And, you know, maybe Rachel, you can speak to this as well, because I know the consortium has brought together a group of folks who are really interested in environmental exposures in Iowa, particularly in ag exposures. At the registry, we're working with folks across the environmental health spectrum and from the Iowa Cancer Consortium to really see if we can dig into this. I think we don't have good data on this right now, but it's definitely something that we're interested in partnering to get good data on so that we can really answer that question.
In just a couple of seconds, I want to say ag chemicals have been tremendously important in making us grow more food. So there's positives to everything. So I'm not trying to throw a whole industry, under the bus, but along with the progress of yield may come along some negative things. So it deserves more research.
Yeah, I would say that, you know, this really needs more research. The radon connection is very clear, and research done at the University of Iowa over a number of years helped to elucidate this and brought policy changes about related to that, which is a really important thing that the Cancer Center has to do. Regarding the other things, I like Sarah's mountain of pebbles analogy, and we do need to understand these other things, but it's also really important, and I think Sarah already alluded to this. We know that there are some of those risk factors that are modifiable, that we have control over, and it's in how one lives their life, not smoking, moderate alcohol consumption, and all of these things. Some of this we really can take better, and then of course expanding our screening and prevention, particularly those cancers that are clearly preventable, like with HPV vaccination, for instance. So, I think there's a lot of things that we can do that are already within our knowledge base, and we should understand those things that we don't know for sure. But we have a lot of things in our control now. So,
that's a really.
Sorry. Go ahead, Dr.
No,
Deming.
you go, Sarah.
I was just going to say, I really love that point, Michael. And just to kind of pull back to the social drivers of health piece, this is why I think policy is really important, and structural and systems approaches, because one cannot engage in physical activity if one doesn't have a safe space to engage in physical activity. Maybe that is a safe park where you feel comfortable engaging in activity, going for a walk. Maybe that's in our rural communities. You have a lit walkway that you can engage. You can go outside and have enjoy a walk. Maybe folks, Rachel already mentioned, I think you mentioned food deserts, Rachel. If you don't have access to healthy foods, then it's a lot harder to consume healthy foods. Things like this is why I also really think there's so many things to focus on, but we also need to step back and think systemically and policy-wise about how we can support everybody. And Dr. Deming, that gets back to your point about equity. Like, how can we ride the tide to lift all boats? How can we do this with equity in mind?
And the magnitude of the issue is huge. So when you look at modifiable risk factors, so those are things like obesity, the food we consume, whether we smoke, how much we drink, etc. Modifiable risk factors account for 42% of all cancers and 45% of all cancer deaths. So that, as Dr. Henry said, if we did what we already know, if we didn't create one new cancer treatment, but we just systematically put into effect everything we know about prevention, screening, early detection, and treatment, we could reduce the incidence of cancer and the death rate by over 40%. And there's no pill we're going to invent tomorrow that is going to have that sort of impact. So part of it makes me think that we when it comes to modifiable risk factors, I bet everyone here on the panel would get an A on the written test on what foods we should eat and what foods we shouldn't eat. But we don't always every day get an A on the practical test. So I'm thinking that, the American Cancer Society maybe should invest in cognitive behavior modification. So how do we systematically get people to modify those risk factors that are modifiable? That would have a huge impact on the incidence of cancer.
And these are things that we can be doing while we are learning about the other things, right?
Yes.
These are things we can be doing now. Rachel, yes. I'm very aware that we haven't let you get a word in edgeways. Is there anything you'd like to?
No, I agree. I'm just like, it's public health. Like that's the answer, is starting in our homes and communities. That's where cancer prevention starts.
I wanted to ask, it's kind of been touched upon, but the screenings and the preventive measures coming out of COVID, I know that there were, what is the impact of COVID on some of that preventive care? Are those levels, are folks getting the screenings and the pieces that they need, or do we know yet?
It definitely took a toll on screening and prevention strategies that I would say, from the things that I have seen, we're still digging out of. I mean, it's still not back to where we were in, say, 2019, and at some of the mammography, colonoscopy, the other common screening efforts. This was a topic of discussion at a meeting that I was at a couple of weeks ago. We're coming back. It's getting better. I think we've had a number of folks, really dig into this, and, one other aspect of this was HPV vaccination. Took one of our the folks here at Iowa, Natasha Askelson, took a close look at this, and it just fell off the the priority list for a variety of reasons, and it got caught up in the whole vaccine discussion to some degree, and that's unfortunate. So I think we still have a ways to get back to where we were even before COVID. Yeah.
Okay. Other thoughts on that, or should? All right.
I totally agree. We did have we intentionally, when COVID, we said, don't come into the hospital if you don't need to. And, it's okay if you skip your screenings this year. But the American Cancer Society did a study, and they estimated that we could have as many as 10,000 excess deaths over 5 years because of the retraction in screening early detection. We are seeing at our own cancer center here at Mercy One Des Moines return to normal screening. So I would say our numbers are back up. But it took a while to get caught up. Let me clarify. Screening colonoscopies, we haven't caught up. We have a backlog of screening colonoscopies that we're trying to make effort to get back to normal. But with our lung cancer screening, our pap smears, and our mammography, we've kind of back to normal.
I'd love to just add to that from the cancer registry perspective too. We also saw a decrease in the amount of cancers diagnosed in 2020. When we look at trends, there's now a dip in the most recent year, and I think we are going to have to be just very vigilant over time in terms of what that means for cancer rates later on down the road. Will we be seeing cancers diagnosed at later stages? Will the rates be going up in 2021? Just the way we collect our cancer data, we are just now kind of completing our 2021 collection. So it takes time for somebody to go through cancer treatment and for us to collect those data. So I think we're just now beginning to understand kind of what that looks like in terms of impact on cancer rates.
Sarah, maybe you could expand a little bit further on the data that you collect. How has that changed? You've mentioned it a couple different, maybe we should collect more data on this, but then also how important is that, and how do you decide what to collect and what's worth the time and the effort?
I could probably spend all day talking about this, but I will try and keep it brief. And it's really interesting. So the Iowa Cancer Registry, we are part of the National Cancer Institute's Surveillance, Epidemiology, and End Results SEER program, which is turning 50 this year. And we actually just celebrated the 50th birthday of SEER last week in DC with the National Cancer Institute. And it was really kind of fun. I'm not that old, so I have no idea what the origins of cancer surveillance was. And so it was really fun. We kind of talked about how back when the Iowa Cancer Registry started, everything was on paper, and we would have had like a really teeny tiny bit of paper that we would have had just the bare minimum pieces of information on somebody's cancer diagnosis, just to tell you how many we had in the state. And over time, obviously, that's developed a lot. We've had the origin of computers, and now our technological advances are just so much further on down the road, and that means we can do is actually collect a lot more information. We have a lot more. What we do is we collect information on the patient, we collect information on the cancer itself, and then on the treatment.
Sarah, do you actually also record the Amazon shopping habits of every cancer patient?
That would be lovely, but actually, I was just about to say the state of Iowa designates us as the public health authority to collect these information. I think we would have a hard time convincing anybody that we needed public health authority to collect Amazon shopping information. And I also personally would be a little embarrassed by my Amazon shopping history, so I'm glad that we don't.
Well, Dr. Deming, how have you seen that data change? I mean, so I don't want to be ageist on the panel.
Yeah, I was in the room where it happened.
There.
Yeah. So the data drives how we invest in screening, prevention, treatment. So it all starts with data. What are the cancers that Iowans are most at risk for? Which ones do we have validated screening tests? And how do we look at not only how many people we're screening, but are we equitably screening everyone who needs screening? And are we, when we determine that we are missing a group? So, for example, prostate cancer screening, the folks that are most affected and have the highest death rate and incidence are African American male. Do we just sit back and talk about our overall numbers and pride ourselves with the increase, or do we then say, well, we know from the Iowa Cancer Report that the mortality for African American men for prostate cancer, and the fact that African American men are diagnosed at a higher stage, that this should prompt us to not just globally advocate for prostate cancer screening, but focus on the areas where it is most in need. So we all quote cancer facts and figures in the SEER data globally, but intelligently, we need to use it to then do a deeper dive and make sure that we are focusing, just as in precision medicine, you want to, in cancer care, focus on that particular case. You want to also use the data to determine where you need to put and invest more resources to have a bigger bang for your buck.
That actually, the next layer down for the Cancer Center has been to study that in some more detail, particularly in the Waterloo community, where there's a very we have one of the highest proportions of African American in the state there. And maybe Sarah, you could tell people a little bit more about what that study's been doing.
Absolutely. So I think it's really more of a partnership. So we have been working with folks. We initially started as kind of an NCI funded study, and then I had some money from the Holden Comprehensive Cancer Center to add to that. And it really started kind of as a conversation between the Cancer Center and folks in the community of Waterloo, Black and African American folks. And through those conversations, we developed what they have called themselves the Black Hawk County Health Equity Steering Committee, I think. Rachel, you can correct me if I'm wrong. This is actually a partnership between folks in Black Hawk County, the Iowa Cancer Consortium, and the Holden Comprehensive Cancer Center. And we've been meeting for probably 18 months to 2 years now, really, to talk about community priorities around cancer. They are very concerned, Dr. Deming, about, as you said, about the rates of prostate cancer and about how folks in the community don't talk about cancer. They don't go in to get the cancer screening. And some of the work that I was able to be involved in, we did some interviews with folks and kind of talked to them about, like, what is it that stands in your way of really engaging with cancer prevention and control behaviors. And there's a lot of kind of medical mistrust and folks kind of not wanting to engage with the medical system. They don't see folks that look like them in the medical system in Waterloo. And so there's just a lot of mistrust there. And so I think that's why partnership is really important. And that's why really bringing ideas from the community and really engaging with those ideas to help kind of amplify those ideas and really implement those ideas can have a lot of impact. And I'd love to pass to Rachel, because I know that the Iowa Cancer Consortium has been involved in this. And I also, as we're talking, I'm thinking a lot about the Iowa Cancer Plan, because all of this kind of feeds into the cancer plan as well.
Yeah, Zach, if it's okay, I'll talk about the Iowa Cancer Plan a little bit. So the Iowa Cancer Consortium, we're a nonprofit organization and we serve the entire state of Iowa. And like I had mentioned before, our job is to really bring partners to the table to have these conversations about where there's disparities, where we're doing well, and be able to kind of talk about best practices and, how do we take something that was successful, in Waterloo and move it to a different area of the state to reduce the burden of cancer. So one of those ways that we do that is through the Iowa Cancer Plan. It's online if you Google it. Our website's cancerio.org. But it's an online plan that basically breaks down into different chapters. You know, what do we need to do to prevent cancer? And we have just like a list of like objectives that we believe if we could make a dent in, we would have a reduced cancer rate. It also goes in to talk about cancer screening, early detection and diagnosis, cancer treatment where we could be doing better, and then also looking at quality of life and equity across that entire spectrum. So our organization does a lot to really push that out to our partners because you know, cancer is so complicated and none of us are going to be able to solve it alone as like one cancer center or, you know, one entity. So we really need to put our heads together and be paddling in the same direction, if you will. And that's what we think the cancer plan serves as for Iowa.
And I would mention the cancer plan. In addition to that, the Iowa Cancer Registry plan is also online. Both reports are fabulous, and I think highly informative, easy to read and understand. And I would highly recommend both of those for folks wanting to learn more. You know, everyone has mentioned policy to some to some degree, and I'm curious if you had a wand and could influence policy, how would you use it? What do you see needs to be changed, and what have the barriers been in getting there?
So I'll just throw out that that having health care as one of the rights of being in the United States would be a huge improvement. There was a time, you know, and Iowa led the way in providing public education K through 12. There was a time in the country where it wasn't automatically assumed that the government was going to provide education for everyone. I think we're at a time where providing health care to everyone would be a huge advancement in the health of this country. We have a healthcare system that's more of a disease care system, where there's no doubt that if you've got a medical problem and have access to healthcare, the United States is the best place to be to have a problem fixed. But we're not the best place to live to have the best health for all of the population. So that would be a huge advancement in the health of the country.
I agree with Dr. Demi. Healthcare is everything. It's everything for your family and for your community. And, you know, to try to tell somebody that doesn't have insurance that they need to go, you know, pay for a colonoscopy. And, you know, after you pay out of pocket for that, then you might have to pay for cancer treatment. That's just like a losing battle for somebody when they already have to face something really life threatening. And I would imagine, I don't know, but that the different hospitals and cancer centers are kind of paying out the nose for like different charity care for when folks do come in.
I think some state level support would be helpful, particularly in the area of prevention and screening. You know, the state supports the Iowa Cancer Consortium, which is fantastic, but they you know, we're not involved in any really large scale screening and prevention programs. And we know there are some issues around the state. Dr. Deming mentioned colonoscopies. We can do better screening for colon cancer, particularly across the lower two tiers of counties in our state, where we know that there are elevated incidents of this, and people are coming in with more advanced disease than they might have had they had better access to screening. So, you know, as I've traveled around to look at cancer centers and in other states, there is often some more support for prevention and screening efforts, because you can really have a big effect at the population level on those sorts of efforts, and that would, you know, bend our numbers, I think, further down from what we started talking about here. So,
is there a state that stands out to you for that as a model, or is it unfair to pick?
Yeah, it's so they're all different. Everybody does it different. Some states actually support mobile screening units, and in a state like ours where distances matter, that's something that might bring the screening access to people where they live rather than having to have them come to a different area. I've seen it in larger cities. It's about getting it into inner city areas where folks don't have really good access to care, or even are aware of what they should be doing or thinking of in screening, and don't have good primary care options. I think it's a similar issue, I think, for some of the access in rural areas. And so I think that's one opportunity that we have to do more in screening and prevention efforts across the state.
Okay, thank you.
The
Dr.
best
Deming,
cancer, the best type of cancer is the one you never get. It's always important. Yeah, it's the one that you don't get. That's the best type of cancer to have. So, yeah.
Well said. Dr. Deming, I wanted to talk a little bit. You started a charity, Above and Beyond Cancer, that has programming far outside of just healthcare after a diagnosis. I was curious a little bit about what led you to start the program. Why did you see a need, and how has that impacted how you deliver care
Yeah, well,
back
thank
to
you.
patients?
So, Above and Beyond Cancer is a not-for-profit cancer survivorship organization that is dedicated to elevating the lives of those touched by cancer. And in this sense, we're defining cancer survivor as anyone who's been diagnosed with cancer. So you might have just been diagnosed with cancer and haven't had treatment. You might have had treatment and you're cancer-free, or you might be living with incurable cancer. We know that it's very important to get the best health care to kill cancer cells, but it's also important to make sure that everyone everywhere along the journey has all the supportive services to make sure that they have the best possible outcome for treatment of the cancer that they're treated for, but we're paying attention to the ongoing physical, psychosocial, emotional, financial, spiritual, philosophical issues that patients have as a consequence of their cancer diagnosis or as a consequence of their treatment. So it's about this holistic approach to how do you have the best life possible, and how do you have a bump in the road of life, like a cancer diagnosis, be potentially a springboard to better living as opposed to a barrier. So it's a philosophical approach to finding joy each day, but it's also an educational approach to realize that you can have a better chance of curing the cancer you've been diagnosed with, and a better chance of preventing a future cancer if you start eating healthy, exercising, have a social support network, do mindfulness, stress reduction, and all of the fellowship. So it came out of my own personal understanding of how do you bring joy into a life that includes eating healthy, exercising, being out in nature, helping other people. How do you bring that life concept to people I care about, my patients and their families? So that's how it got started. Here in the twilight of my career, I've also had the opportunity to create an integrative medicine program within the cancer center. So Above and Beyond Cancer happens out in the state parks and city parks and the YMCAs and the healthy living centers. The integrative medicine program within Mercy One Cancer Center is bringing into the cancer center things like massage therapy, acupuncture, chiropractic care, osteopathic manipulation, physical therapy, mental health counseling for patients, mental health counseling for family members, sexual health resources, mindfulness-based stress reduction, music therapy, art therapy, and all of those are being brought into the cancer center. Not that those things kill cancer cells, but taking care of patients and their families is more than just killing cancer cells. It's supporting them everywhere along the way.
Can you talk a little bit about how that's impacted you as a medical provider, I would imagine it's difficult to be, the deliverer of news um, for a diagnosis. How has that impacted you?
Yeah, you can't stay in the field of oncology unless you have an acceptance of, number one, your own mortality and the fact that we are all mortal. Um, I don't think there's such a thing as compassion fatigue. I think that individuals who have burnout are because they try to shield themselves off from having appropriate emotional attachments to people they care about. And I think having a doctor who cares about you as a person is a good thing, and that it's good for the patient and good for the doctor. And I'm reminded of one of my favorite quotations from the Dalai Lama. If you want others to be happy, practice compassion. If you want to be happy, practice compassion. So I would say this type of patient-centered, compassionate care is kind of like a hug. It works in both directions. And that engaging in this type of practice of medical care is not about experiencing compassion fatigue. It's about being engaged and having that greater sense of professional fulfillment that even those patients, not every cancer patient can be cured, but every cancer patient can be healed. And the ability to heal those that are living with incurable cancer allows you to feel good about what you're doing and not just feeling like you are futilely spinning wheels and not making any advancement. So I think it helps both the patient and it helps the caregiver.
Okay, I know we're getting close on time, but I wanted to touch on AI, particularly because I think it's an evolving space. But I'm curious how you see AI and some of these other, tools entering the toolbox. But I'm also curious how you see it influencing education and just being able to stay aware of all of the developments that are happening at an extremely rapid rate. And
Yeah, and I was gonna say it's kind of like terrifying and could also be a really good thing. I know I read just a couple articles about how it could impact cancer screening. So not that we're not going to need radiologists, but if you can imagine this smart machine that's able to look at 500 x-rays, mammograms in like a second, and be able to use that knowledge to maybe help alleviate some of the burden on the radiologists, or just to make us smarter, because it can go through that information so quickly. I think that could be really exciting. I really do.
Yeah, that's one of the angles that AI I think is going to have an impact. It's a lot of different things. It's where any situation where you have lots of potential information coming to bear to help decision making and guide what happens with a patient, AI may have a role. And one of the things is trying to determine which patient is eligible for a clinical trial is not actually a trivial exercise, and takes some mind space and thought and knowledge and energy on the part of a number of people to do that. And so AI is potentially positioned to take a look at the medical record and a lot of other sets of data and assist someone with deciding is a clinical trial appropriate for someone. And so that's another area, in addition to just how it will affect our basic understanding of this complex disease. Cancer is an amazingly complex disease that ultimately manifests in a very individual way in every patient. And the power that AI can bring to looking at lots and lots of data all at once to find patterns that humans are hard pressed to find on their own. They may reveal insights about the underlying mechanisms of disease that we haven't really been able to appreciate up to this point. So Yes, there are a lot of concerning things about AI. I agree with Rachel. It's kind of the brave new world, but there are certain potential benefits that it brings too, and I think we're going to have to balance the risks and benefits as we go forward. So,
excellent. Well, I know we could go probably all day talking about some of these different topics, but we've reached the end of our time together. And so I just want to say thank you to all of the panelists for both your willingness to participate today and also what you're doing to help Iowans with this issue, because I think it's crucial work that is something that everybody doesn't necessarily appreciate on an ongoing basis to the level that they should. So I appreciate your time today. For the participants here, we're taking our lunch break, and the next sessions start at 1:20. So thank you, everyone.
Great. Thanks.
thanks.
Thank you.
Bye.
Thanks, everybody.